Okay, good morning everyone to this winter carnival and the state of the winter wonderland. So today I am going to present a case presentation on unilateral Urrets-Zavalia syndrome after implantation Collamer lens, and it is a case report with a review of literature. Thank you. So let's start with introduction. Urrets-Zavalia syndrome is characterized by the fixed dilated pupil with associated iris atrophy and in some cases secondary glaucoma. First reported by Urrets-Zavalia in 1963, following penetrating keratoplasty for keratoconus, the condition was initially attributed to the prolonged mydriatic use. Subsequently, this syndrome was described after lamellar keratoplasty, penetrating keratoplasty for corneal dystrophies, trabeculectomy, and after implantation of phakic intraocular lens. It is generally agreed that this syndrome is related to the high intraocular pressure and iris ischemia. A 25-year-old male presented with a poor vision in both eyes due to bilateral myopia with astigmatism. Best corrected visual acuity was 6.9 in the right eye with minus 7.25 diopter sphere, minus 2.5 diopter cylinder at 30-degree axis, and 6.9 in the left eye with minus 7 diopter sphere, minus 3 diopter cylinder at 150-degree axis. On slit lamp examination, anterior segment was normal and endothelial cells counts exceeded 2600 cells per millimeter square in both eyes. When we see the fundus in right eye, the discs were normal, macula is normal, and periphery is also within normal limit. When we see the left eye, disc and macula is normal, and periphery also seems to be within normal limit. When we see the pentacam, we can see the K1 and K2 is 41.2, 43.2. Axial curvature map is normal. Front and back elevation seems to be normal with corneal thickness of 543 and AC depth with 3.54. When we see the in balance is also normal. When we see the left eye, axial curvature map is normal. Front and back elevation seems to be normal, and corneal thickness is 552 with AC depth of 3.45 mm with normal balance map in left eye. So, our patient was given both the options, SMILE and phakic lens implantation, and patient was keen for ICL. So, phakic lens implantation was planned for both eyes. Star online calculation and ordering system or cost software was suggesting ICL of 12.6 mm in both eyes. So, we started with the right eye and we implanted ICL in the right eye in the anterior chamber, and the haptics were placed in the ciliary sulcus. Patient underwent right eye ICL surgery with 12.6 size, and surgery was uneventful with post-operative vision and volt of 6 parts and 271 micrometers respectively. Due to high astigmatism in the left eye, we planned with a 13.2 size, which is much bigger and with predicted volt of 550 microns. So, left eye surgery also went uneventful, and the volt seems to be adequate on the table. However, on post-op day 1 follow-up, the patient presented with severe pain and redness with eyelid edema, diffuse 360-degree subconjunctival hemorrhage, chemosis, corneal edema, IOP of 70 mm height of mercury on rebound tonometer. History reveals 6 to 7 episodes of forceful vomiting on the previous night. Vision and volt of the left eye was 6/9 and 568 micrometer respectively. Aggressive IOP control was initiated with IV mannitol and oral and topical anti-glaucoma medications. With no relief after 4 hours, slow decompression from side ports was done and IOP decreased to 21. Surgical video of left eye was reviewed and confirmed that adequate visco was done at the end of surgery. Despite medical therapy and AC decompression, next day IOP rose again to 50 mm height of mercury. AC was along with surgical peripheral iridectomy, and ICL footplate reposition was done. So you can see how the severe the subconjunctival hemorrhage was there, and so AC was done on the post-op day 2, and ICL footplate were repositioned. IOP gradually settled at 1 week, 2 week, 1 month at 21, 14 and 16 mm height of mercury respectively. Anti-glaucoma medications were gradually tapered. Pupil remained fixed and mid-dilated. So we can see that pupil remained fixed and mid-dilated. So this is the one of a study where we have a record of first post-op day till 5th year. We can see the improvement in vision, we can also see the changes in volt, and we can also see the changes in IOP. So what did we learn from this? IOP spike can unpredictably complicate an uneven full ICL surgery. Viscoelastic removal must be more than meticulous. Hydroimplantation of an ICL is a useful option. Minimal IOP spike with minimal volt changes. Never belittle the risks and complications when counseling a patient for surgery. Let's review some cases. QMIL was the first one to report UZS with ICL implantation in 2011. This is one another case reported in 2021. They also had a same case in right eye. It was normal, but in left eye they had a UZS syndrome. And they also came with the same conclusion that the pupil remained semi-dilated at the end of 1 month. This is the third case which were reported in 2025. And it was also, that case was seen in China. The case reported emphasized the possibility of a fixed mydriatic pupil associated with IOP rise as a potential complication after the implantation of posterior chamber IOL. Okay.